This talk's going to be about the acute coronary syndromes, which are unstable angina, NSTEMI, and STEMI. If you haven't seen the slides on angina yet, you should probably look at that before you watch this. So we talked about angina being chest pain with exertion, and we talked about stable angina in the angina slides, and that's chest pain with exertion that's relieved with rest. Unstable angina is going to be chest pain with exertion that's not relieved with rest, or it can also be classified as chest pain that's brand new or worse than previous episodes. So in any angina, the pain is going to be substernal. It's going to be described as crushing or heavy, and it's the pain that lasts minutes to hours. It's not going to be days to weeks. So if the patient comes in and they say, I've been having this chest pain for the last 5 or 6 days, that's not angina. So sometimes you may have radiation to the upper arm or shoulder. That's not necessary, though. It's just one thing that is commonly seen in angina. And angina is always a sign of coronary artery disease, as far as we're concerned. So this is, again, this diagram that shows sort of the classification, the nomenclature of angina. So angina is just the chest pain, the substernal chest pain. And then we have stable angina, which is when it's relieved with rest, unstable angina when it's not relieved with rest. And then unstable angina is broken into 3 different categories. And so if you have an MI, which would be the non STEMI and STEMI, then this is characterized by the thing that these two have in common is that the cardiac enzymes will be elevated. And that's simply because there's enough ischemia to the heart cells that you're actually getting some necrosis. And so you're spilling out cardiac enzymes. The non-MI unstable angina is just the angina that's not relieved with rest, but you don't have positive cardiac enzymes. The way you tell non-STEMI and STEMI apart is based on EKG. So any of the unstable angina diagnoses are classified as the acute coronary syndromes, which is going to be the focus of this talk. And any angina is due to coronary artery disease, as far as we're concerned. The only exception primarily is Prinzmetal's angina, which I gave a brief blurb to in the angina section. Okay, so here's a vignette. 62-year-old man with a history of hypercholesterolemia presents to the ED complaining of substernal pain that he describes as crushing. He says these episodes are brought on by going up the stairs or chasing after his dog, and this episode has continued despite rest. This is unstable angina. So this is a patient that has unstable angina, which when we have a patient that is older, when I say older, I mean over the age of 50 or 55, when they have symptoms that are consistent with unstable angina, even if it's just regular old angina, we need to get an EKG. And the reason is the risk for angina, or the risk for myocardial infarction when angina is present, particularly unstable angina, is so high, and an EKG is so cheap and so easy that it is the most prudent next step. And the reason is because EKG is going to tell you if you have ST elevations, which if you have ST elevation, you're going to move right on to treating STEMI. EKG won't tell you the difference between non-MI unstable angina and non-STEMI, but it will help you weed out STEMI right away, and that needs to be treated as soon as possible. So your next step, anytime you have a patient with unstable angina, is to get an EKG. You should also get cardiac enzymes, but if you're asked on the USMLE what is the next step in the management of this patient, your answer is going to be EKG. So you're also going to have your cardiac enzymes. Meanwhile, you should be giving this patient aspirin, a beta blocker, and nitrates, usually nitroglycerin is fine, and supplemental oxygen. You should also give the patient morphine for pain relief. Now, aspirin, a beta blocker, and just aspirin and the beta blocker, as far as we're concerned here, those increase the survival rate. They decrease mortality. So you should know that. The nitrates are good for the pain. The supplemental oxygen is good for comfort, and the morphine is good for pain. Those are all useful. We give these, yes, to reduce pain, but also because when you have pain, what happens? Your heart starts pumping more. Your heart rate goes up. And the more the heart has to pump, the more oxygen your heart is going to require. So that's why we like to give these patients nitrates, supplemental oxygen, and morphine. But it's also for the pain, too. The beta blocker reduces the amount of oxygen demand, and that actually increases the survival rate. So you should know that aspirin and the beta blocker are absolutely necessary. Those are at minimum necessary. The nitrate, supplemental oxygen, and morphine are given, but they don't increase the survival. The treatment is going to vary based on the result of the EKG and enzymes. So your enzymes, like I said, will tell us if it's an MI or not, but usually you're going to have the EKG first. So you get an EKG and you have ST elevation, your diagnosis is STEMI. You don't even have to wait for the enzymes. If you have ST elevation of more than 1 millimeter in more than 2 leads, then you have a diagnosis of ST elevation MI. If you don't, then you don't know if it's non-STEMI or just non-MI unstable angina. You'll have to wait for your enzymes to come back. If the enzymes are positive but the EKG is equivocal, then it's going to be non-STEMI. You're not necessarily going to see EKG changes in non-STEMI. You could see EKG changes in non-STEMI. What you would see is signs of ischemia rather than signs of infarction. And remember that signs of infarction are going to be ST elevation, so that's how we get STEMI. Signs of ischemia are going to be ST depression. So if you see ST depression, that's a hint towards non-STEMI. But ST depression does not have to be there to have non-STEMI. What you would have is elevated enzymes in the presence of a normal or ST depressed EKG. So very important to be able to tell a non-MI unstable angina and then non-STEMI and STEMI. Okay, so here's your cardiac enzyme. So the most important one, the most specific one, is going to be your CKMB. And so here's your CKMB. It's here in the dotted pink. So the reason that this is useful is that it's going to be one of the first to peak. And so you'll have, usually within 4 to 12 hours, you're going to have an elevated CKMB level. So you'll have an appreciable CKMB level very quickly, but you'll really start to notice it after 4 hours. The nice thing about CKMB is that within 2 days, it's back down and normalized to an appreciable level to where if you have a new infarction, you would see a rebound in your CKMB. So CKMB is good for the initial diagnosis, and it's good for when we have this patient who's had an MI and they're in the hospital and we're checking them for reinfarctions because we are concerned about that, then the CKMB will be something that we'll look for. Troponin is also good. It helps us with our diagnosis, but notice how it stays high for so long. And so it's not going to help us for diagnosing reinfarctions, but it will be positive in patients who have an MI. Okay, so I've kind of gone over this, but I really want to make this clear. So what is the difference between STEMI and non-STEMI? So let's first talk about what they have in common. So STEMI, which is ST elevation MI, and non-STEMI, which is non-ST elevation MI, they both cause cardiac enzyme elevation. So they're both going to cause increases in your CKMB and increases in your troponin. So that they have in common. They're both life-threatening emergencies that require treatment. Non-STEMI can progress to STEMI. It doesn't always. It doesn't have to. They're both dangerous, but you have to keep in mind that both of these are life-threatening emergencies, so they have to be treated with emergent care. And then both can be diagnosed as anterior, lateral, inferior, anteroseptal, posterior, and so forth. So we're going to look at how you can have different leads that are going to have ST elevation or ST depression, and that's going to help us diagnose where exactly in the heart this occlusion or this ischemia is, what artery, and that's going to be helpful when we go in to catheterize the patient. So STEMI is a more severe occlusion which causes a transmural ischemia. So the occlusion is so severe that you have ischemia from the outer layer of the heart all the way to the inner layer of the myocardium. So this results in an ST elevation because what you actually have here is an ischemic lesion. And so that results in an ST elevation in the relevant leads based on where it is, if it's anterior, lateral, so forth. And in these patients, we are going to give them, if it's less than 3 hours since the onset, we are going to give them fibrinolytics. It does increase the survival. If given within 3 hours, it increases the survival by 50%. So we do want to use fibrinolytics on these patients because we would break the clot down. There's already a clot in the patient, so we want to break that down. With non STEMI, what we have is a blockage that causes a superficial ischemia of the myocardium. So it's not full thickness. And so that's the reason it doesn't cause the ST elevation. This may or may not result in ST depression. So if you see ST depression, you should think non STEMI, but ST depression itself, all by itself, doesn't mean non-STEMI, and the absence of ST depression doesn't mean you don't have non-STEMI. So you can't just look at that. What you look at to diagnose non-STEMI is the absence of ST elevation and a positive cardiac enzyme. And in these patients, we're going to give them heparin. We're not going to give them fibrinolytics, and the reason is because they don't have an occlusion. All they have is a blockage. They don't have a complete occlusion. So in these patients, we don't use fibrinolytics. And the fibrinolytic I put here is tissue plasminogen activating factor. That's the most common that we use. Okay, so this is an example of non-STEMI. This is an EKG, and so look here. Look for the abnormalities. So here you got 1, 2, 3, AVR, AVL, AVF. So here's your limb leads and here's your precordial leads. Where's the abnormality? Now you don't have to have this abnormality to be diagnosed with non-STEMI, but it is present a lot of times. And so let's say you got this EKG and you have cardiac enzymes that are positive and you have this EKG. You know that it's non-STEMI because you don't have ST elevation anywhere. But what you do have is ST depression, and the ST depression will help us diagnose where the non-STEMI is. And the ST depression is right here, in V4, V5, and kind of in V6. So the fact that you have ST depression in V4 and V5, notice that the baseline is right here. The depression is all the way down to here. So since we have it in more than 2 leads, we have a non-STEMI. And it's V4 and V5, so this is probably a lateral occlusion. So this kind of is a schematic of what I just showed you. Here's another non-STEMI. So look for the ST depression here. You kind of see it in 2 here, but where you're really going to be paying your attention primarily is 1, 2, AVF, and then the precordial leads. So here's the depression right here, most prominent in V2 and V3. So this is more of an anterior infarct. So I know I didn't talk about how you diagnose anterior, lateral, anteroseptal, posterior. We will bring that up in another section. I can't remember if I put the slides on here or not for that. Okay, so here's STEMI. So this is ST elevation. So remember, when you have a patient coming in with unstable angina, you get that EKG right away, because if you have ST elevation, you want to pick that up right away. You don't want to be waiting for those cardiac enzymes to come back, because if you have ST elevation, this patient's in big trouble. And if you have the ST elevation, if this patient is in big trouble, you will see that ST elevation. And look at it, it's very obvious here. ST elevation right here. This is your QRS complex here, and this is your elevation. So you have elevation here, elevation here, elevation here, and even a little bit on V4. So 1, 2, and 3. So this is an anterior ST elevation MI. Possibly even anteroseptal. You can't really diagnose it on EKG alone, but it gives you a clue. So here's the ST elevation. This is kind of a schematic what it looks like. P wave, QRS complex. And then because your baseline is, or your baseline's down here, because your ST region is so high up, it's going to make the T wave look like it's peaked. So if you kind of go back here, it looks like you got peaked T waves. This isn't hyperkalemia. This is just your ST elevation. So you do have what looks like a peaked T wave. This is like your T wave right here, but this is just an ST elevation. So this isn't peak T waves. This isn't hyperkalemia. So this is just ST elevation. Same here. This isn't normally your T wave should only come up this high, but what you have here is an elevated ST segment. So this is ST elevation. It is not a peaked T wave. So just something to keep in mind, the difference between the two. And your symptoms should point you immediately towards infarction and not towards hyperkalemia. Okay, so where are the ST elevations here? They are right here. So you got 2 and 3 and AVF. So if you remember back to EKG, 2 and 3 are both your leads, the limb leads that look downwards. And AVF also looks downwards. This is the lead that's placed on your leg. So 2, 3, and AVF look downwards. So when you have ST elevation of 2, 3, and AVF, that is significant for an inferior MI. So this is inferior wall MI. So how do we manage? So now we're going back to unstable angina and non STEMI. So we've diagnosed the patient with non STEMI. They have got positive cardiac enzymes, and the EKG shows no signs of ST elevation, meaning no ST elevation of greater than 1 millimeter in more than 2 leads. Nor do they have a new left bundle branch block. If a patient has left bundle branch block, which I'll show you an EKG of in a little bit, that also will classify that as STEMI. So they have no ST elevation, no new left bundle branch block, but they do have positive cardiac enzymes. Well, okay, so first of all, before we even get the cardiac enzymes, when we have a patient with unstable angina, like I said, we're going to be giving the patient aspirin, beta blocker, and heparin. Okay, we're always going to do that. Then we're going to also give them supportive care, so 100% oxygen, nitrates, and morphine. So this is what we always do for any patient with unstable angina that may be just regular non-MI unstable angina or NSTEMI or STEMI. When the patient is now diagnosed with non-STEMI, we're going to catheterize them. So we have to catheterize them if it's non-STEMI. If it's unstable angina, we don't necessarily have to. So when we catheterize the patient for angiography, that's in the case of non-STEMI, so if the cardiac enzymes come back positive. But we're also going to catheterize the patient, even if it's unstable angina, if they have had a prior MI that's required intervention, so PCI or CABA. Any MI would require intervention. So if the patient has a history of any intervention, so percutaneous coronary intervention or CABA, or if they have CHF or chronic kidney disease, or they develop hypotension, or they've had prolonged pain, those are all indications for angiography. So know that these indications, and know that always, if you have diagnosed non-STEMI, you're going to catheterize the patient. Whenever you catheterize the patient, you're going to give them clopidogrel, which is an antiplatelet drug, and a GP2B3A inhibitor, which, if you remember, is eptifibatide and tirofiban. So we always do that for patients that are getting catheterized, clopidogrel and a GP2B3A inhibitor. And then if it's greater than 12 hours of the symptoms, or if PCI fails, then CABA is indicated, and that would go off to the surgeon. Okay, so here's that left bundle branch that I was talking about. This is a left bundle branch block. If you see this in a patient who's got elevated enzymes and they've got unstable angina symptoms, or even possibly even if they just have unstable angina symptoms, but I'm pretty sure the USMLE would give you the elevated enzymes if they threw this at you. If they have elevated enzymes and a left bundle branch block, you're going to treat this like STEMI, not like non-STEMI, even though you don't have ST elevation here. So the left bundle branch block, what it is in the QRS complex, when you have ventricular conduction, and the conduction is going through the left ventricle, you have an infarct there, and that infarct interrupts the QRS complex. And so what we get here is a little, kind of a little notch in our QRS complex. And you can see here, this is more of a normal QRS complex that you see in lead 1, but in lead 3 and in lead AVL and AVF, you see this little notch on your QRS complex, and that's a left bundle branch block. And so this is going to be treated as STEMI. Here's another one. So here's one in AV3, AVF, and 2. And you'll also see the, when it's a left bundle branch block, you'll also see it well, not necessarily very prominently, but you'll see it in V1, V2, V3, and V4. When it's a right bundle branch, or I'm sorry, you'll see it in V3, V4, V5, and V6. When it's a right bundle branch block, you would see it in V1, V2, V3, and V4. And that all has to do with where the leads are placed. So remember your precordial leads. V1 is on the right side of your sternum, V2 is on the left side of your sternum, and then V3, V4, V5, and V6 kind of wrap around your chest where your heart is. V4, V5, V6, and V3 are on the left side, and V1, V2, V3, and V4 are kind of considered on the right side. So a left bundle branch block you'll see in 2, 3, AVF, and you'll see it in V3 through V6. A right bundle branch block, which we don't see here, would be seen in V1 through V4. And what I'm talking about seeing is just that little notch. Okay, so here's our algorithm on how to treat unstable angina and non-STEMI. So we've already kind of gone through this, but this is kind of more of a graphic view. So angina lasting 10 to 20 minutes or more that's not relieved by rest. Our first step is going to be an EKG, and we're also going to want to get enzymes. Now, I actually should have put this up here because you're not going to wait for your EKG. You're going to get your EKG first, but at the same time, when you're in the hospital, at the same time, you're going to be giving them aspirin, beta blockers, heparin, and the supportive care. But note that you're doing all this at the same time, but when they ask you on the USMLE what's your next step when the patient comes in with unstable angina, your next step is EKG. So EKG and enzymes. If the EKG comes back and it's ST elevation, it's STEMI. So we'll talk about that next. If the EKG comes back and there's no ST elevation or no new left bundle branch block, then it's considered unstable angina or non-STEMI. We don't know yet because we're waiting on the enzymes. While we're doing all this, like I said, we're administering aspirin, beta blockers, and heparin. All 3 of those increase your survival. And then administering supportive care for the pain. 100% oxygen, nitroglycerin, and morphine. Once the enzymes come back, if the enzymes are negative, then if there's no other indications for angioplasty, then we can discharge the patient or observe. And remember what those other indications were for angioplasty. Those would be the patient has had a prior intervention, if they've got congestive heart failure, chronic kidney disease, hypotension, or prolonged pain that's not responsive to nitrates. In that case, if their enzymes are negative, it's not non-STEMI or STEMI, then we consider this just unstable angina that's been treated, and we can discharge them or admit them for observation. But we don't need to do angioplasty on these patients if they have no indications and their enzymes are negative. If their enzymes do, though, in fact come back positive, or the patient has one of the other indications for angioplasty in the setting of unstable angina, so hypotension, CKD, prior intervention, or prolonged pain, then we're going to treat this as non-STEMI. It is non-STEMI if the enzymes are positive. And so what we then decide to do is, if the time since the onset of the pain, so you ask the patient, when did the pain start? If it was less than 24 hours ago, you're going to send this patient in for angiography or for PCI. Well, they'll probably do the angiography and the PCI at the same time, but your next step is angiography. And if they ask you what drugs to give before the angiography, you're going to give them a GP2B3A inhibitor and clopidogrel. If it's been more than 12 hours or the PCI fails, if the angioplasty fails, then they're going to go in for CABA. All right, so let's say that we've got this patient now and we've diagnosed them with STEMI. They have an EKG, they have unstable angina, they come in, we hook up the EKG, and they've got ST elevation greater than 1 millimeter and more than, this should say greater than or equal to 2 leads. 2 leads or more. Or they have a new left bundle branch block that hasn't been diagnosed before. We will treat this as STEMI. So this would be STEMI, and EKG changes are presumptive for the diagnosis. So if you have the EKG changes, do not wait for your enzymes. You're going to treat this patient right away. So we'll give them aspirin, beta blocker, and TPA. We're not going to give them heparin here. Why are we not going to give them heparin? Because in STEMI, the clot is complete. It is generally a thrombus. And so you have a complete blockage. Remember what heparin does. It prevents clots from forming. TPA breaks up clots. So what we want to do in these patients is break up clots, not prevent one from forming, because we already have a clot. We only give TPA if it's less than 3 hours from onset. And generally, these patients are going to come in right away because STEMI is significant pain. So aspirin, beta blocker, and TPA if less than 3 hours from onset. We're also going to give these patients the same supportive care: oxygen, nitrates, and morphine. These patients are going to be catheterized for angiography. So we're going to administer clopidogrel and a GP2B3A inhibitor. And then from that point, we look at the catheterization after we've given them TPA. If the recanalization is successful, meaning if we've broken up the clot and the EKG changes subside, then we can admit this patient and we perform angioplasty, percutaneous coronary intervention, PCI, within 24 hours. If the TPA is unsuccessful at breaking up the clot, or the patient is more than 3 hours from onset, meaning we can't give them TPA, or there's contraindications for TPA, meaning that they've got a recent bleed, they've had recent surgery, then we give them, we're going to perform rescue PCI immediately. So we'll just go straight to angioplasty. We won't wait the 24 hours or do it within the 24 hours. If in any case the PCI fails, if we're unsuccessful at stenting this patient and restoring circulation, then we're going to proceed to CABA, and so this will be in the surgeon's hands. What you need to remember for the USMLE is that thrombolysis, TPA, is never the final treatment. After you give them TPA, you're either going to admit them and perform PCI within 24 hours if you've successfully recanalized, or we will perform a rescue PCI immediately if the recanalization is unsuccessful or we can't administer TPA, either because it's too late or because there's contraindications. So this is our STEMI algorithm. So angina that is lasting for 10 to 20 minutes, not relieved by rest. As mentioned before, we get EKG and enzymes, and we would see an ST elevation here or a new left bundle branch block. At this point, we're treating STEMI, so we're going to administer aspirin, beta blockers, and TPA if it's less than 3 hours and there's no contraindications. We'll also give them the supportive care as usual and catheterize them for their angiography. So the USMLE is not going to ask you about supportive care. I put that there because you might see it come up on the USMLE as what is the best medical management for this patient, or which of the following is going to increase survival. Just keep in mind what the supportive care is and what the medical care is. Aspirin, beta blockers, TPA, or heparin, depending on whether it's STEMI or non-STEMI, respectively. Those are your medical treatment because that is going to increase survival. The oxygen, the nitrates, the morphine It's good, you do it, but it's not necessary because it's just supportive care. It's not going to increase survival. So these patients, any patient with STEMI, we're going to catheterize them. So we're going to give them their GP2B3A inhibitors and clopidogrel. If we have a successful recanalization, we will admit them to the coronary care unit and do a PCI within 24 hours. If it's not successful, then we're going to do PCI immediately. If that PCI fails, we'll move on to CABA. So remember the 3-hour window for TPA. So this I just want to cover. When do we use PCI and when do we use CABA? So remember the workup for when we use PCI and CABA. Remember how we do it in the stable patient. So the patient with stable angina, we're working them up. We want to know if we have to revascularize this patient with stable angina. How do we do this? Well, we get the angiography that tells us whether we do PCI or CABA. It's a patient that has stable angina. They've came back positive on their stress test, and now we want to know if we do PCI or CABA. We give them the angiogram, and we find out that they have single vessel disease. In that case, we do PCI. Very easy to put a stent in one vessel. If they have multiple vessel disease or left main artery disease, then they're going to need to be surgically operated. And so in that case, they're going to have to get bypass surgery. Now, when we have an MI patient, we're going to do angiography right away. We're going to try to do PCI as soon as we can, because in stable angina, what we usually have are little occlusions in multiple different places. In MI, what we have is a thrombus in one place. And so you have in unstable or in stable angina, what you have are little clots in a lot of places, but that aren't fully blocking the artery. But in MI, what you have is one totally occluded vessel that's causing a big problem in one specific area. So that's why we get angiography always in MI patients. And we're going to do PCI. We're going to attempt PCI right away because we have a clot in one specific area. And so we can do PCI. Whereas in the stable patient, we want to look, do we have, because we're not in any emergency in the stable angina patient. Does this patient have just a significant blockage in one vessel? In which case, yes, PCI we can do. Or do they have significant blockages in multiple vessels? In which case, we're going to want to do a more thorough treatment of this patient, so we do a coronary artery bypass. But when the patient has MI, we know that the problem is really only going to be in one area. The big problem is only in one area. So we're going to focus on that emergently, and that's why we do PCI. If the PCI fails, then we do CABA.